This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to Fellows Conference this morning. We have Dr. Austin Rim, who was an Emory resident and then joined our academic clinical investigator pathway and now is in his first year of clinical time. He's going to be talking to us about exercise recommendations, and he does have some questions built into his talk. So please drop your answers in the chat, and I don't know you, Austin, I don't know if you can see the chat, so I'll monitor it and call out what the answers are.
Cool. Sounds good.
All right, go ahead, get started.
All right. So we can just get started with the first question. Morning, everybody. For those of you who are listening through chat, question one is, which of the following statements are supported by high quality evidence from meta-analyses of randomized controlled trials of structured exercise programs or from large observational cohort studies of habitual physical activity? Letter A, structured aerobic exercise programs typically lower systolic blood pressure by about 8 millimeters of mercury. B, self-guided exercise interventions reduced A1C by approximately 1 percentage point. C, regular physical exercise is associated with approximately 3 to 4 additional years of life expectancy compared to inactivity. And D, all of the above.
Great, I see some answers coming through. I see a lot of D's, which to be honest with you was my answer too. Yeah, pretty consistently D.
Cool, okay. All right. So next question, and we'll get to the answers at the end. Question two, a 52-year-old man with hypertension walks briskly for 30 minutes, 4 days per week, and also does vigorous spin class for 15 minutes once weekly. Does he meet the U.S. physical activity guidelines in cardiovascular exercise? A, yes. B, no. C, only if his heart rate exceeds 70% of the max. And D, unknown. The proper metrics are not available to answer this question.
Answers are slowly trickling in. I see some B's. I think the answers have stopped there. So B seems to be the most consistent. B, but not sure, one says.
Nice. Everybody's on the B train, I can see. All right. And then lastly, which of the following statements best reflects the dose response relationship in physical activity guidelines? A, the most significant mortality benefit occurs when moving from no activity to some activity. B, most benefits only appear after meeting 150 minutes, I should include moderate intensity exercise per week. C, exercise after 300 minutes per week are associated with worse outcomes. And D, only vigorous activity reduces cardiovascular mortality.
Got a couple of A's, a lot of A's.
Cool.
A
Awesome.
seems
Okay.
to be the consensus, yeah.
All right, so I will reveal the answers at the end, and I'm really excited to kind of go through this because I think there are a couple of really important teaching points or learning points to go through with physical activity. Just getting started a little bit about myself. I included this picture. This was like 11 years ago when I was working at a public high school as a teaching assistant, and I got bullied into running a half marathon for the first time. And I think my perception of exercise was like, you should either commit fully and make sure that you're like have like a very intense goal, like, and if you're not running 13 miles, then it's not worth it. But I think the important thing that I'm learning through this research and also through my time in sports cardiology is that, any amount of exercise is good. You don't necessarily have to be doing incredible things, or not that running a half marathon is incredible or anything, but you don't have to, be physically exerting and training for a race in order to get the physical benefits of doing exercise. And so the goals for this talk is by the end of this, I'm hoping that you will be able to give some effective counseling to patients, families, and peers, and even potentially take some advice for yourself about the cardiovascular benefits and physical activity, and also be able to define the evidence-based thresholds for the minimum and optimal amounts of exercise required to improve cardiovascular health and reduce mortality. So I think we all know that we should be counseling patients on physical exercise, but don't necessarily know what the best way to do that is. I think a lot of the conversations go something like this, like exercise is good for you, or you should really exercise more, or for those of us who are talking a little bit more in depth, it's exercise reduces your risk of heart disease and diabetes, right? And then we can sign off saying that we counseled them on exercise, maybe diet, and then, sign off on our names. But I think there's a lot more that we can do in terms of counseling our patients about what the best strategies are for physical exercise and why it's so important to do it. One thing that I always find kind of interesting is like, how do we know that physical activity lowers cardiovascular risk? And some of the first studies came out in the 1950s, and surprisingly from London. It was a study from the London Transit Authority that studied about 31,000 transit workers. They found that bus conductors who basically were walking around and collecting fares basically had about a 50% decrease in coronary heart disease compared to those who were sedentary the entire day. And many of you probably know about the Harvard physical activity or the Harvard alumni study, which followed these collegiate alumni over the course of their lives. And they found that people who, this was actually one of the first studies that was able to describe a dose dependent relationship between physical activity and decreases in cardiovascular disease. And so kind of getting to the bulk of this conversation is what should our advice be for most patients who are coming to us asking for advice on physical activity? And here it is. It is at least 150 to 300 minutes of moderate intensity aerobic exercise. You can actually cut it down in half if you are vigorously exerting yourself, and that's about 75 to 150 minutes. You can also mix and match, right? And so one way to think about it is 1 minute of vigorous intensity exercise counts for 2 minutes of moderate intensity aerobic physical activity. In the United States, we also recommend 2 days a week of muscle strengthening activities. And these are guidelines that are also endorsed by the WHO or the World Health Organization as well. This is also endorsed by the 2019 ACC guideline of prevention, primary prevention. We should all be counseling our patients on living an optimally physically active lifestyle. And they should also be engaging in the aforementioned sort of thresholds. And so I think it's important to just define what a moderate intensity and vigorous intensity exercise really is. For moderate intensity exercise, that is 3 to 5.9 METs. 1 MET is just us sitting right here, not really exerting ourselves. That is how much energy we need in order to just basically lay flat. Moderate intensity exercise is walking briskly, 2.5 to 4 miles per hour, maybe playing volleyball, raking the yard. Vigorous intensity exercises, jogging or running, carrying heavy groceries, or participating in a strenuous fitness class. So basically, if you are raking the yard for 3 hours a week, then you meet the prescribed goals. But it can be a little bit difficult sometimes to really get an idea of, what moderate and vigorous intensity exercise is, especially, across the spectrum, right? Somebody who's a track and field athlete at the age of 18 is going to have a different threshold for exercise compared to somebody who is living with heart failure, right? And so one way that we have a rule of thumb for this is just looking at this on the side, moderate intensity exercise activities. We can think about while you're doing them, you can talk and maybe gossip, but you can't sing during the activity. And for vigorous intensity exercises, you really can't say more than a few words without pausing for a breath. And so for meeting physical activity guidelines, this is just like a really straightforward way to think about it. If really practical advice to give patients or for yourself, if you want to meet it, you can just walk briskly for 30 minutes, five times a week. If you are more interested in potentially cutting down that time, you can jog at 5 miles per hour, 25 minutes, 3 times a week. And I learned this a lot later than I should have, but literally, if you just press the 5 button on the treadmill, that's literally 5 miles per hour, six being 6 miles per hour. And so I wanted to go into the trends of adherence to physical activity guidelines in the United States specifically. And you can see from 2008 to 2016, the percentage on the y-axis of individuals who are meeting this slowly increases, but we still have a long way to go to get good adherence for physical activity guidelines. Um, you can see that men have a trend of having a little bit of a higher adherence, maybe closer to 25%, while women are around 19%. But as we'll get into a little bit later, I do wonder whether or not there is a difference. This is all self-reported information, and there are data showing that men may over-report the amount of physical activity that they complete. And so I think one important thing too is understanding the inequities in physical activity levels as well. Here are little charts that I made that are coming from data from these different papers. One is physical activity adherence stratified by income. And you can see on the left side of this bar, you can see that people who are making less than $15,000 a year have a much lower adherence to physical activity guidelines compared to those who are making more than 50,000. It's maybe 12% compared to about 27%. And this is also found with education levels, right? People who have less than a high school degree uh, have a lot lower adherence to physical activity guidelines compared to those who have finished college. Um, One thing to note I thought was interesting is that people often over-report the amount of physical activity, and I think that's important to keep in mind because a lot of the research that we have, especially when it goes to the prospective observational studies, are completed using a lot of these survey data, right? And so in this one study that was done in Canada, 1,751 adults wore an accelerometer and completed international physical activity questionnaires. So they were able to see whether or not the objective amount of activity that they had correlated with the amount of actual physical activity or with the amount that they had reported. And what they found is that over 7 days, sedentary time was underestimated by about 2 hours. And men overreported the amount of moderate to vigorous physical activity compared to women by about 47%. But when they actually broke down the accelerometer data, there were actually no differences between the two sexes. And so this is a really interesting paper from BJSM, British Journal of Sports Medicine, that showed on the x-axis you can see increasing intervals of physical activity. So going from sedentary to 75 minutes per week and 225 minutes per week. On the y-axis, you have the hazard ratio. And they split up the studies from people who self-reported, or these were all meta-analyses of self-reported uh, mortality rates among people who met physical activity guidelines. And as you can see, the hazard ratio starts to decrease pretty significantly early on. But what's really interesting is that when they compared it to studies that use accelerometry, so objectively figured out whether or not you were meeting these um, goalposts, that the hazard ratios were a lot lower. So I think what this shows is that people often over-report the amount of physical activity that they're doing, and that meeting physical activity guidelines could probably actually help us even more than we think that they would. And so one way to think about this is like understanding the little bits and pieces of physical activity and how it affects traditional cardiovascular risk factors. And I'm primarily interested in talking about hypertension, hyperlipidemia, type 2 diabetes. And so this is one study that was a pooled meta-analysis of 93 randomized controlled trials, including over 5,000 participants. On the left, we can see that this is showing the different types of lifestyle modifications, breaking it down from physical activity, weight loss, dietary modifications. And you can see that across the board, there's pretty strong evidence that physical activity decreases blood pressure, systolic blood pressure, on average, decrease maybe anywhere from 3 to 5, and diastolic blood pressure was anywhere from 2 to 3. And you can also see that cholesterol or LDL decreased somewhat significantly, right? From anywhere from -3 to -5. You can say potentially that aerobic exercise was a little bit better, but honestly, any sort of exercise was helpful in reducing systolic blood pressure and diastolic blood pressure. There's also really interesting data about the relationship between moderate to vigorous physical activity and the incidence of type 2 diabetes. Right over here on the x-axis is the amount of met hours per week. And on the y-axis, we're seeing the relative risk of the incidence of type 2 diabetes. I put this little dashed blue line in the middle showing where the minimum thresholds for US guidelines are. And each one of these lines represents a different meta-analysis. And these were all put together into one graph. This basically shows that as physical activity increases, the relative risk of incidence of type 2 diabetes progressively decreases. And as far as these studies show, there isn't necessarily the biggest gains are to be found early on. But as you go on further and further, it plateaus, but there isn't necessarily any specific cutoff point where the benefit stops. There's also another way to think about physical activity and diabetes, and that's by looking at the A1C reductions. And these are two different meta-analyses that I put together. One is looking at the Cochrane analyses. This was 377 participants. And this was specifically looking at exercise-only interventions. And what they found is that people who were engaged in physical activity, and this is a wide-ranging amount of physical activity. It could be 30-minute sessions that were moderate to vigorous intensity, or it could be 90 minutes all bulk at once doing sort of Tai Chi. And basically what they found was that as long as you're making at least about 120 minutes of moderate intensity exercise, you could have a pretty noticeable decrease in your A1C, about 0.6. In JAMA, there was another meta-analysis that was published. This was much larger. It was 5,000 or 8,538 participants, about 47 RCTs. And this was a little bit more expansive in the sense that it also included studies that had dietary interventions. And so on in the red, I'm showing basically the JAMA studies. For this one, it's just diet and exercise. It is just advice and diet, basically meaning that the physician or somebody else gave the participants some advice about physical activity, making sure that they were understanding what the physical activity guidelines were saying, and people who are also given diet advice maybe were able to decrease their A1C by 0.42. Those who had structured physical activity, meaning that they went to classes that were guided for over 150 minutes per week, actually had the greatest decreases of A1C, close to 0.9. Of note, all of these trials were at least 4 weeks, if not 8. But I think one of the really interesting parts is that even for such short trials, they were able to find pretty significant results. But I think there's a couple of ways that you can see these data, right? One is that um, it is impressive that we are able to find significant decreases in cardiovascular risk measures like blood pressure, A1C, uh, LDL, just by exercising and not taking another pill. Um, but another way to think about it is that, wow, like, these are actually kind of modest reductions, right? Like I have so much, I can understand if you're telling me like, hey, Austin, like I have so much difficulty in getting my patients to, remain adherent with their medications. Like, how am I going to get them to take a walk for 30 minutes, 5 days a week? Um, and like, I think the reason why I include these slides is in part to show that there are reductions in cardiovascular risk, but um, I think it's important to understand that it doesn't necessarily capture the whole story when it comes to physical activity. This is kind of an old study. This was done in 2007, but I think it is great at portraying this one singular point in that this is a study of 27,000 um, female healthcare workers, and so nurses and physicians, and they followed them for over 12 years. And they found that the the people who were the most physically active had much lower cardiovascular risk compared to those who were inactive. And they basically made a bunch of Cox proportional hazard models and adjusted for all the different types of cardiovascular risk factors that we knew, as well as some novel risk factors such as lipoprotein A. And they found that after adjusting for all these known risk factors, they could only explain about 59% of the benefit of physical activity, meaning that maybe around 40% of the benefits of physical activity for cardiovascular risk could not be explained by what we already know. And so the reason why I say this is because physical activity um, is really able to exert its benefits not only through traditional risk factor improvement like hypertension, A1C, hyperlipidemia, but it works in ways that we don't even quite understand, and that there's a lot of benefit to be gained, even if we don't necessarily see reductions in those numbers like A1C and systolic blood pressure. And so this is really kind of getting into the next point. How does physical activity affect all-cause mortality? Right. So this is one of the largest studies I was able to find, and forms a lot of the basis for the US guidelines that were published in 2018 about physical activity. And it is on leisure time physical activity of moderate to vigorous intensity, exercise, and mortality. And these are all the studies that are put together. It includes studies like the US Radiologic Technological Study, Women's Health Study. In total is over 650,000 individuals. It has a bit more women than men. The median age was around 61, and people were followed for at least 10 years. There was a lot of people who were also prior smokers. This is a relatively healthy population as well. About 16% of patients had comorbidities. And just stratifying this further by level of METs, you can see that there's a pretty wide range group that was um, involved. There's also a large span of education levels. One thing that I think is a significant limitation of this, though, is that there's barely any diversity in this study. So one of the biggest things that was found or was portrayed, I think, in this meta-analysis is that there was no lower threshold for the benefits of physical activity. And you can see that in this chart right over here. On the x-axis, leisure time physical activity, met hours per week, going from 0 to 30 METs. 150 to 300 minutes of moderate physical activity is within this bar, so somewhere between 8 METs and 16 to 17 METs. You can see that there is an early decrease in mortality, the hazard ratio for mortality with any level of physical activity. And then about 70% of the benefits were reached once people were meeting about 8.25 MET hours per week. And so that's about 150 minutes to 300 minutes of moderate physical activity. But what I think that's also interesting is that even as you continue to follow this line down, there was no evidence of increased risk towards the high end of physical activity. I think this is another way to look at it. They're basically um, doing some statistical tricks to figure out the years of life that were gained by physical activity. And what you can see here is that there is a steep incline as well with minimal amounts of activity that continue to increase. And right over here is close to where the physical activity guidelines are, about 8. And people who are able to meet those guidelines on average gain about 3 to 4 years of life. Sometimes it can be a little bit difficult when we're chatting with patients to get a great idea of how much physical activity that they're actually getting. And I think one way that we can actually do it is by asking them to pull out their phone and say, like, hey, like, do you track your daily step count? I remember a couple of years ago, there was some confusion about whether or not daily step count is associated with lower all-cause mortality. And this is a meta-analysis that was published in JACC. Of 12 cohorts, there was over 100,000 individuals, pretty widespread, and these studies were adjusted for age, BMI, smoking status, alcohol, education. And they also found that with increasing steps per day, there was a decrease in all-cause mortality and incident cardiovascular disease, with optimal amounts is closer to 7,000 and 8,000. But they were also able to find significant reductions in mortality with just 2,500 steps a day. And so, again, I think I'm harping on this point a little bit. But as you can see through all of these charts that I presented, that um, there is uh, there is benefit to be gained at any level of physical activity, and especially the slope is the steepest early on. The last thing too is that I think I touched on it a little bit by talking about the women's study where they were only able to account for 41% of or 59% of the benefits of physical activity on the differences in mortality between physically active people and inactive people. But physical activity just does a lot of things for people, right? It improves quality of life, reduces anxiety, reduces depression, improves sleep. These are all things that have been studied, and there's rigorous data behind these claims, right? And so sometimes I tell patients, like, if I could somehow find a medication that was able to, pack all the benefits of physical activity into a pill, I'd be a millionaire, right? But fortunately enough, anybody can get it for free. And so I would be remiss by not talking about cardiac rehab and exercise training as well. Um, Cardiac rehab and exercise training maintain class 1 indications for a variety of cardiovascular diseases, including coronary artery disease, heart failure, valvular heart disease, LVAD, heart transplant. And so physical activity is not only for people who are able to move their bodies, but is also for people living with a variety of cardiovascular conditions. In fact, the US guidelines also state that people living with disabilities should also aim to get the same amount of physical activity that we set for the general population. And so going back to the questions, which of the following statements are supported by high quality evidence for meta-analyses? I kind of tricked everybody a little bit, I think, because I feel like all of these are always about like I feel like these questions are always trying to get you to be like, oh, like, of course it does all of these things. But in actuality, C is the correct answer. Regular physical activity is associated with approximately 3 to 4 additional years of life expectancy. I think a really important message to drive home is that cardiovascular physical activity improves life, um, and decreases morbidity and mortality through ways that we don't necessarily understand, right? But the effects are significant. Question 2 is this 52-year-old man with hypertension walks briskly for 30 minutes, 4 days a week, and does vigorous spin classes for 15 minutes once weekly. This patient actually does meet U.S. physical activity guidelines. Remember that rule. You can do 3 times 4, which is 120 minutes of moderate intensity exercise, and then you can double that 15 minutes because every minute of vigorous activity exercise counts for 2 minutes of moderate intensity. And so that patient meets 150 minutes, basically meeting the US physical activity guidelines. And then last, which of the following statements best reflects the dose response relationship in the physical activity guidelines? I think everybody got this one right. Is the most significant mortality benefit occurs when moving from no activity to some activity. So I think so the key takeaways are really these 3 things. The magnitude and consistency of mortality reductions associated with meeting physical activity guidelines, I think is greater than what we see for any single cardioprotective drug, right? And I think, of course, medications play a huge role in terms of reducing risk. But for the general population, uh, meeting physical activity guidelines carries significant improvements in reduction in mortality risk. Second thing is that physical activity is most effective when it is sustained in a routine part of daily life rather than an intermittent intervention. And so if there is any way that we can tie physical activity to daily routines, for example, sometimes I like to talk with patients about walking even 5 to 10 minutes after a meal can significantly reduce their risk of cardiovascular disease as well as mortality. And the last thing is that even small amounts of activity confer measurable cardiovascular benefit, right? As we could see in the previous graphs, is that there was the steepest slope in reduction of mortality early on in any of these graphs that were portraying cardiovascular morbidity and mortality. And the dose response curve begins at a very low level and rises steadily. All right, thanks. I'm happy to take any questions.
Thanks, Austin. That was a really great review of physical activity and the guidelines and some of the data. I pretty much always, when I try to get patients to do more, talk about walking because it's easy and it's cheap and accessible. I wondered if there was any, like in your reading, any like reason to sort of push something other than walking, like, biking or something else.
Yeah, not necessarily. And so I think there's some question about whether or not vigorous activity may be more beneficial compared to moderate intensity exercise like walking. Um, there's kind of mixed data in terms of whether or not vigorous intensity exercise really outweighs the benefit of moderate intensity exercise. What they have found is typically that volume of exercise is the most important thing in terms of reducing cardiovascular morbidity and mortality. And what I would say is that whatever sort of physical activity that your patients are more likely to do is the one to recommend.
Austin, hello, Lena Dalmato. I used to be a fellow at Emory, now I'm not. But I actually had a question for you. You touched upon that regarding the physical activity, that the benefits still kind of go up even if you do significant physical activity. But did you even look at it? If there is a difference in, let's say, half marathon runners versus marathon runners, like more into like advanced kind of athlete category, if there is a cardiovascular benefit, or the other way around, it actually the benefits of cardiovascular benefits do not weigh the risks of like, I don't know, orthopedic injuries or something like that.
Yeah, no, that's a great question. And I think it comes up a lot in the sports cardiology research world. One thing that I will say is that in a couple of studies, I think there is one Copenhagen run study that was showing that high volumes of vigorous intensity exercise was potentially correlated with slightly higher mortality risks. And there's a little bit of a talk of a J-shaped curve in terms of increase in mortality at high levels of physical activity. Um, that study has come under a lot of controversy because the confidence intervals are so high that there was a low amount of people who actually experienced mortality at those high levels. What I will say is that in the meta-analyses, as you can see earlier on, is that there doesn't appear to be any sort of leveling off point. I'm sure there, if you are running like 12 hours per day every day, there is probably going to be some negative consequence that you incur. But as far as the RCT data show and the meta-analyses are strongest forms of evidence, it doesn't appear that there is necessarily a higher limit. What I will say is that there have been data that shows that there is perhaps a higher risk for the development of atrial fibrillation in people who are exerting themselves a lot at the level of marathon runners or Ironman runners. There is a question about whether or not there is increased coronary artery calcification. It does appear that there is, but it doesn't necessarily mean that there is increased risk for mortality in these individuals.
Austin Stan Sherman. These studies, they are averaging not much more than 60 years old, I think, and our patients are getting older. And any studies go above these levels, or some exercise recommendations for older patients?
Oh, sorry. Was the question, are there any specific?
Has there been any studies with older patients? That it sounds like the age group for these studies was maybe as much as in the 60s, but any for in the 70s in terms of extending life.
Yeah, I think so. Fortunately enough, I know most of these studies have medians of individuals who are in their 60s, but the span was wide. And I would say that I'm not sure whether or not I saw in these meta-analyses whether or not they did subgroup analyses of older individuals. But I know for a fact that these recommendations apply to everybody, anybody over the age of 70 as well. I am sure that there is mortality benefit as well and life extending um, benefits for people who are over the age of 70, but I haven't necessarily seen exactly how it comes out. I'm sure, like anybody who is 120 is not going to get 3 to 4 years of life by exerting themselves. But there are a lot of benefits of physical activity when it comes to decreasing frailty, increasing mobility, improving mood as well, that even if you don't necessarily get as much increase in life expectancy, that there's still benefit to doing physical activity routinely. All right. Well, I think that's it. I'm not sure if I'm the one who sort of like.
That's okay. Yeah, we can wrap up. Thanks everyone for coming today. And Austin, great job.
The preceding program is copyrighted by Emory University.